would like to acknowledge the traditional custodians of the land that we each meet on today and pay my respect to elders past, present, and emerging. And just a quick reminder that the information presented in this webinar is of general nature and should not be taken as specific medical advice, and you are encouraged to discuss any matters of concern specific to you or your family with your own medical professional. I would now like to welcome Professor Carol Pollock, who is an academic nephrologist with over 390 publications in basic research and clinical medicine. Her work has been cited over 23,000 times. She has a number of standings, including the Chair of Kidney Health Australia, Deputy Chair of the Board of the Australian Organ, Tissue and Transplant Authority, Chair of the New South Wales Cardiovascular Research Network, and is an inaugural Fellow of the Australian Academy of Health and Medical Services. Thank you, Carol.
Thanks, Charmaine. I appreciate the introduction, and I'm very happy to be here to be speaking to everybody today. So what Charmaine's asked me to do is to talk about aspects of autosomal dominant polycystic kidney disease, and specifically the use of Tolvaptan in patients with ADPKD. So I thought I'd start off with I should do slideshow here, shouldn't I? I thought I'd start off with a sort of a historical slide that starts in 1585 with King Stephen Bathory, who was the King of Poland. And he died at the age of 56 when he came off his horse and was found to have died. He had an autopsy, and they said that he had kidneys with the size of bull's testicles, and that was really pretty much the end of the autopsy. But in 1888, the term polycystic kidney disease was coined, and then in 1933 there was the 400th year anniversary of King Bathory's birth, and they reviewed the autopsy results and the cause of death, and it was considered then he died of polycystic kidney disease and uremia. So 400 years later. Now, it wasn't until 1989 that it was recognised that this entity of cyclic AMP dependent fluid secretion was part of the pathology of polycystic kidney disease. And we'll go into that, but I only raise it because 1989, I'd already graduated from medicine, for 7 years. And, it just astounds me the rate of knowledge that's progressed, since I graduated. So they had identified PKD1 as an entity in 1994 and PKD2 a couple of years later. It wasn't until the early 2000s that they recognized that vasopressin receptor antagonists, which are really Tolvaptan, and I'll go into that a bit more, could be used for reducing the severity of kidney disease in animal models. And then since then, there's been an explosion of trials and of approaches to try and support good kidney function in people with polycystic kidney disease. So I think if you look at kidneys in people with polycystic kidney disease, you can see that early on there's cysts, not too many, but the diagnosis does depend on having more than 3 cysts in each kidney. But as you can see, as time goes on and age progresses, the number of cysts increase and the kidneys get bigger as a result. And so the cysts replace the normal functioning kidney tissue. And you get to a point where the kidney volume and TKV is total kidney volume, increases to a point where then the GFR, or the rate of filtration of the kidney, if you like, eGFR can be considered as percentage kidney function. And it's not till the kidneys get to be quite big that the filtration of the kidney starts to decline. So that's, the kidneys are growing, and then they start to fail. And we've known that for a long while. So the Mayo Clinic, which we all recognise as being an icon in terms of medical research, have really looked at this, at the size of the kidneys, and looked at whether or not it's likely that there's going to be decline in kidney function over time. So they've looked at these different classes. So class 1A to class 1E. I don't know why they decided it was called 1A, 1E instead of just A to E. But they look at the size of the kidneys and then whether or not they're going to decline. So you can see here that people with the biggest kidneys, class 1E, are likely to have the most precipitous decline in kidney function. And that's this, this line here on the red. So if your kidneys are bigger, they're more likely to fail sooner. If they're smaller, then you're here and they're less likely to fail. So here we've got nearly 80% of kidney function, and 20 years later, there's still 60% of kidney function. So it's really the people with big kidneys, and you can see here, this is the imaging where there's, almost the entire kidney replaced with cysts, and you can't really see normal kidney tissue in between. And they're the, they're the kidneys that we worry about. They're the people that we worry about. So several years ago, there was a study looking at whether or not people who were treated with, blood pressure medications to lower their blood pressure to quite low blood pressure limits actually improved their kidney function. Now, we've been aware that people who have high blood pressure, and particularly with protein in their urine, are likely to have accelerated decline in kidney disease. So people with diabetic kidney disease, for instance, have high blood pressure and high levels of protein in their urine. People with polycystic kidney disease have potentially high blood pressure, but not a lot of protein in their urine. So we didn't really know whether lowering blood pressure was going to be as impressive in restricting the decline in kidney function as what it was in people with higher levels of protein. So this is the HALT study, and they randomized people to receive antihypertensive medication, in this case, a particular group of drugs called ACE inhibitors versus ACE inhibitors plus angiotensin receptor blockers versus no additional treatment for their blood pressure beyond what their treating physician had prescribed. And they randomized them to have a blood pressure of between 120 and 130 systolic. We mainly worry about that top level, not so much the bottom level these days, versus a blood pressure of 95 to 110. Now, if you look at the general population who have a blood pressure of between 95 and 110 probably live longer than people who have blood pressures between 120 and 130, even though these are both regarded as being normal. When they looked at the study after, the follow-up, which was, up to 96 months, so almost 2 years, you can see that if they were treated with standard blood pressure medication, then the kidney volume increased. And we know that when the kidney volume increases, then that portends future decline in kidney function. So that was an increase over and above people that were randomized to be treated to target low blood pressure. So that was a significant difference. If we look at significance, we measure that in a medical sense by the p-value. And if we look at the p-value, we regard it as different if the p-value is less than 0.05. And that means there's less than a 5% chance that that would happen by chance. In this case, it's a p-value of 0.006. So that's less than a 0.6% chance that that would happen just randomly and almost by accident. So we know that if you've got really blood pressure control, that it slows the growth of the kidney. Now, I don't know whether or not you can see this graph, because on my screen, I seem to be obstructing the graph, but there didn't seem to be a change in filtration or the percentage of kidney function over time, despite there being a slowing of the growth of the kidney. And that's probably just a function of timing. You know, maybe by virtue of slowing the growth of the kidney, we're not necessarily going to see an improvement in kidney function for 5 years hence. And we didn't do this, or when I say we, I'm using the royal we. They didn't do the study long enough to see that that translated to protection of or preservation of kidney function over time. So lowering blood pressure actually decreases the rate of growth of the cysts in the kidney, but it doesn't necessarily slow the decline in kidney function. They then did an analysis, a post hoc analysis. That means something that wasn't specified when they originally set the study up 4 years later. And they looked at the different patterns of how people's kidney function really sort of varied when they had polycystic kidney disease. And you can see that some people had a progressive decline in kidney function. Some people had a up and down course. So, we recognize that sometimes the kidney function drops, it'll come back up, it'll drop again. And some people were rock solid stable. So about 2/3 of people have this pattern. About 20% of people go up and down, and about another 20% say are completely stable over time. And when they looked at the factors that might cause you to have a decline in kidney function, then it seems like obesity is something that people with polycystic kidney disease really need to avoid. So if you're overweight, the chances are twice as high that you'll have a decline in kidney function. If you're obese, and that's a body mass index, which is a function of your height and your weight, it's more than 3.7 times more likely that you'll have a decline in kidney function compared to somebody with polycystic kidney disease who is of normal weight. So I think it applies for more so for this change in kidney mass, the total kidney volume, more so for the eGFR decline, or the percentage decline in your kidney function. But again, I think that is probably because the HALT study only went for 96 months, so not even, or I think 96 weeks, not even, a couple of years. So I think it just behoves everybody to make sure that they have a healthy lifestyle and maintain a healthy weight. So when we look at the drugs that we've got available and the future drugs that we might have available to treat autosomal dominant polycystic kidney disease, there's been a couple of drugs that initially we thought might be positive, but they didn't turn out to be. So the mTOR inhibitors, and these are drugs, probably everolimus is the most common one used in Australia at the moment. Sirolimus is another one. But although it can inhibit the cyst or the fluid secretion, it didn't seem to have a long-term benefit on kidney function. Similarly, somatostatin, which is a sort of something that modifies hormones, lots of hormones, that looked like it could have been positive, but again, didn't turn out to be positive. So there's now quite a few studies that are underway, and Australia is participating in some of them. You can see there's relatively few numbers, like 100 people, 560, reasonable number of people in this study. Only 31 here, 200 here, 36. There's not a lot. There's a couple of studies that I haven't put on here. One of them we're involved in at the moment, which is the IMPEDE study, which is looking at metformin, and metformin inhibits that the hormone that makes cysts grow in the kidney, and we're looking at that as a treatment because it's been around for, I think we started using metformin for people with diabetes in about 1956. So we know that it's safe and we know it's not going to cause any problem. And theoretically, it might be of benefit. Some of these other drugs, are some more experimental than the others, but you might be approached to be a part of some of these different drugs and therapies. Now, I'll just focus on Tolvaptan. Now, I think most people with polycystic kidney disease would be aware that maybe not, but the kidneys filter 180 litres of fluid a day. And most of the work in the kidney is in reabsorbing that fluid. So we only really pass about 1 litre or so of urine per day. So a lot of people are a bit surprised when I tell them that they've got kidney failure because they say, but I'm passing a lot of urine. And so they equate passing a lot of urine with good kidney function, whereas actually passing more urine in chronic kidney disease can actually mean that the kidneys aren't functioning properly because they're not reabsorbing it. So here we look at a cell in a kidney, and here we've got what's called the tubule lumen. So the urine's coming down here, and there's various receptors and hormones, etc., that sense when you've got to reabsorb more fluid, if you're dehydrated, for instance, or if blood sodium level gets too high. That's a signal to reabsorb more water from the urine and bring everything back into sync. So to stop you from being dehydrated, to stop your sodium level from getting too high. And what happens is that there's a sensor in your brain that says dehydration, high sodium level, better release this hormone vasopressin, that then gets into the circulation and then into the kidney on this vasopressin receptor, the vasopressin 2 receptor. And then that stimulates cyclic AMP and then allows water to be reabsorbed back into the system. But when you've got polycystic kidney disease, this system is somewhat disrupted, and you make cyclic AMP, but it basically, cyclic AMP drives cell proliferation and cyst growth, and it also drives fluid reabsorption, but it puts it into the cyst rather than puts it back into the circulation. So what Tolvaptan does, it inhibits this vasopressin receptor to stop the generation of cyclic AMP. Therefore, it stops cyst growth, stops the fluid reabsorption that causes cyst growth. And therefore, by limiting cyst growth, it doesn't cause pressure on the normal kidney tissue that is continuing to function normally. So basically, Tolvaptan can stop the cyst growth. That's how it decreases the kidney size, and it also preserves normal kidney function, but it causes you to pass more urine because you're not reabsorbing the fluid. So by virtue of its beneficial effects, the side effect is that you pass more urine. So based on these animal studies that demonstrated there was a benefit in blocking that vasopressin receptor, there was the initial study done in humans called the Tempo 3-4 study. Now, I don't know why it was called the Tempo 3-4 study, but that enrolled a large number of patients. So you could see from that prior slide, there was at most just over 500 patients. Tempo 3-4 enrolled 1,445 patients between the ages of 18 and 50 who had relatively preserved kidney function, but who had quite big kidneys. So by virtue of having big kidneys, they were destined to have a decline in kidney function. So they were predictably going to get worse. So if you're going to do a trial, the theory is you pick people who the treatment might positively impact on. So if somebody's going to be stable, then if you treat them with something and they stay stable, it might be the treatment, it might be because they were always going to stay stable. But if you pick a group who, by virtue of having big kidneys, are likely to decline, then that's the group that you want to see, does your drug make a difference in? So the primary endpoint, which is, basically how, you determine, what is the key outcome that you want from the trial, and they determined it was the rate of change of kidney volume, because the rate of change of preserving kidney function might just have taken a bit too long. So that's the primary endpoint. That tells you how many patients you need in the study. And then you do secondary endpoints. And these secondary endpoints included this rate of functional decline in kidneys, in kidney filtration. And it was a 36-week follow-up, so it was quite short. It wasn't like they were following people for 5 years to see if they got a benefit. So if we look then at the results, in blue is the Tolvaptan treated patients, and in the red is the placebo treated patients. So these were the placebo and not treated with anything other than air. So you can see the people who were treated with Tolvaptan had relatively stable size of their kidneys, whereas people who were treated with placebo had a progressive increase in the size of their kidneys that was, over time. Actually, I think I said 36 weeks before, it was 36 months. When you look at this sort of a graph, this is what's called a forest plot. And if anything is on the right-hand side of this line here, then the placebo, it has a better outcome. If it's on the left-hand side of the zero line, then the Tolvaptan treated patients had a better outcome. So they've looked here at, who benefited most for a preservation or a reduction in the increase in total kidney volume. So you can see both males and females had a reduction in their kidney size. If you were less than or more than 35 years of age, both those groups, it wasn't like if you were older, you did better. If you were younger, you did better. If you had high blood pressure, yes or no, you still did well. If your creatinine clearance, so your kidney function, your percent of kidney function was less than 80% of normal versus more than 80% of normal, you still did well. And if your total kidney volume was bigger or smaller, then you still did well. So overall, Tolvaptan did better on all of these measures. Everybody benefited from being on Tolvaptan compared to not being on Tolvaptan. If we look at the kidney function, and this is percentage decline in GFR, so whether or not function is going to deteriorate, again, there was benefit in favour of being on Tolvaptan. So it didn't happen for 16 months to 2 years, but then the lines started to diverge, and people who had been treated with Tolvaptan tend to have a preservation in their kidney function. People treated with placebo tended to have a decline in kidney function. And when you look at those groups, this is the other way around now. Now tolvaptan beta is on the right. And if these lines cross the 0 point, then statistically you can't say that that group is benefited. But you can see that the mean values, which are the squares, are all better if people were treated with tolvaptan. Males and females equally benefited, but it does seem that people over the age of 35 were somewhat better, I guess, afforded benefit by being on tolvaptan compared to if they're less than 35. People who had high blood pressure seemed to do better compared to people who didn't have high blood pressure. Again, it didn't matter what your starting kidney function was like, you still benefited. And to some extent, if your kidney function was bigger, if your kidney size was bigger, then you tended to do better compared to if your kidney size was smaller. So the people likely to do worse were the people with bigger kidneys, and they were the people who were most benefited by tolvaptan treatment. So if we then look at the summary of benefits, and now we've again got tolvaptan on the left-hand side, placebo on the right-hand side, and we can see the composite of various sorts of aspects of what make up things that bother people with polycystic kidney disease. So if we look at worsening kidney function, then the tolvaptan group does better compared to the placebo group. If we look at kidney pain, the tolvaptan group does better than the placebo group. Most people don't have much in the way of protein in their urine, albuminuria. There's no difference. So if you receive tolvaptan versus if you don't, there's no difference in albumin. Most people don't have that much albumin, probably not significant. Tolvaptan of itself doesn't seem to change blood pressure, but when you take into account all of these different components of just tolvaptan benefit, then it does appear to benefit in this composite. And that means this p-value of less than 0.01 means there's less than a 1% chance that that benefit would have occurred just by chance. So it does appear statistically that tolvaptan is giving benefit. So if we then look at the composite event rate, you can see here that this is tolvaptan in the blue and placebo in the red. And over time, you can see that people treated with placebo have more events compared to tolvaptan, a 13% reduction in events in the tolvaptan treated groups. So that is worsening of kidney function, reduction in kidney pain, etc. So the tolvaptan treated patients. Now, if we just look at worsening of kidney function by itself, you can see there's no real benefit that you can see on your blood tests for 16 months. And after that, then the kidney function tends to get worse in the placebo, and it tends to stabilize in the tolvaptan treated group, such that by the end of the 36 months, there was a 61% risk reduction compared to the placebo group in terms of reduction in risk of worsening of kidney function. If we look at kidney pain, and kidney pain, as many of you would know, is either due to an increase in the size of the cyst or a rupture, there's a hemorrhage into the cyst, or sometimes infection in the cyst, or sometimes a stone in the cyst. Now, this doesn't differentiate what all of those causes of kidney pain are due to, but it does say that there's a 36% risk reduction in the patients treated with tolvaptan compared to placebo. So then everyone said, well, that's all very well for tempo 3-4, but they're only people between the ages of 18 and 50, and all of their kidney function was good. The GFR was more than 60% of normal, so they had stage 2 kidney disease. What about people who might be older and with more impaired kidney function? So they did the Reprise study that was 1,370 people aged between 18 and 55 years with lower GFRs, so between 25 and 65% of normal, or even older people, and I should be careful about older people, but an older population between 56 and 65 with GFRs that were, relatively low. So this is stage 4 and up to stage 3B. And they followed them up for 12 months. And they looked at the primary endpoint now being the change in eGFR from baseline. So here you can see, this is where they started. They were pretty similar in terms of their GFR. When you start on tolvaptan, there can be a reduction of a couple of mils per minute. It can be up to 5 actually, that we expect to happen with tolvaptan. Now, it can be because there's a fluid loss and a reduction in hydration status, but there's also factors that happen within the kidney that decrease the pressure within the kidney. And we think that's a good thing in the long term. All of the other medications that we know that protect kidney function in the long term do it by decreasing the pressure in the kidney. So we expect that there will be a reduction, but then we also expect that if you're treated with placebo, there is a decline in kidney function that's deeper than the kidney function decline with tolvaptan. So you can see this here is declining at 3.6 mils per minute per year. This one treated with tolvaptan is 2.34 mils per minute per year. So there's a difference here of about 1.3 mils per minute per year. Now, that doesn't sound a lot when you say 1.3 mils per minute per year, but translate that over 20 years, and in 20 years, you're going to have something like 26 mils per minute more kidney function than what you would have had if you hadn't been treated with tolvaptan for 20 years. It obviously depends on where you start, but these small changes in decline in kidney function over the long term can translate into very marked benefits in retention of kidney function. So again, if we look at this plot here, and again, it's the same forest plot where everything to the right means tolvaptan exerted a benefit. Anything that crosses over this line of 0, we can't say much about it. So we can see all patients benefited, mostly people who were less than 55, not so much people who were more than 55. But then again, we have to consider the other characteristics of patients that were in the study. Males and females, again, equally benefited. Interestingly, people who were Caucasian seemed to benefit more than people who were non-Caucasian. This is largely the Black African American, and you can see the numbers aren't very big. So you don't want to make too much of this. But it's interesting because there's a lot of racial differences in terms of the Black African American responses to different drugs. So here we look at the baseline GFR. Doesn't matter if your GFR was less than 45 or more than 45, still benefit. And the benefit does appear to be more in the people with stage 3A, 3B, or stage 4. So stage 2, again, not very many people in Reprise, because Reprise was trying to sort out whether or not people with lower degrees of kidney function. So stage 5 is almost on dialysis or on dialysis. Stage 4 is less than 30% of kidney function. Stage 3B is less than 45% of kidney function. Stage 3A, less than 60% of kidney function. And stage 2 is between 60 and 90%. So you can see in Reprise, small numbers here for stage 2, but it certainly did benefit people who had later stage kidney disease. And also there are often geographic regional differences, and they looked at that. There didn't seem to be any. So then, these studies are relatively short. So they enrolled people who had completed either the Reprise or the Tempo 3-4 studies, and then continued to follow them up at the end of these studies and looked at, whether or not there was any long-term benefit. So this here isn't a large number of patients, but there were 97 patients treated for more than a year, and they were up to 11 years. And what they did was they looked at 3 different approaches, comparing the decline in kidney function. So you do that by the slope, how rapid is it versus how slow is it. And then they did an arbitrary 33% reduction, so a third of a reduction from baseline eGFR, and looked at that compared to various controls. They looked at whether or not, if you were treated, there was any difference in the rate of decline. So maybe the first year or 2 you were protected, but maybe it wasn't long lasting. And then they looked at if you compared, if you predicted the same decline, was that the decline you ended up with versus the measured decline. So here is these 58 patients that had been then observed between 1 and 5 years, and 39 patients up to 11.2 years. And you can see here the probability of not decreasing in terms of your kidney function by at least a third was better in the Tolvaptan group. So there was a 37% risk reduction by virtue of being treated with Tolvaptan, so better preserved kidney function compared to placebo in the red. And then if we look at the, if we take out that initial drop in GFR, I told you we expect that that decrease in pressure in the kidney might cause an acute drop in kidney function that we expect, and it might actually be a good thing in the first month. Then you can see if we take out that first month, then the benefit is even greater. So you can see here Tolvaptan causes preservation. By the time you get to 10 years, there's very few people. So you want to look at the main part of the graph where there's more people from which to make an assumption. Both of these are statistically significant. So that's unlikely that the benefit would have been by chance. So then if we just summarize the studies that I've just talked to you about, then Tempo 3-4 looks at early ADPKD, people whose GFR was still preserved, stage 2 CKD, GFR above 60, more than 60% of kidney function, 3-year duration, reduced kidney growth, by almost half, or half the rate, and it reduced GFR decline by 26%, which is 1 ml per minute per year, but it's still 26% in terms of comparison to placebo. And it reduced all the, the pain, the hematuria and the urinary infection. Reprise, that was in people with more significant polycystic kidney disease and also in an older population, it reduced the kidney decline by 35%. So if anything, slightly better than if the kidney function was, sustained. And the follow-up studies suggested that this benefit was sustained over time. Now, one of the issues that people who are taking Tolvaptan would realise, we make everybody have liver function tests on a monthly basis. And that's because about 5% in these studies basically have abnormal liver function tests. If we stop the drug, they generally come back to normal, but we don't want you to keep taking the drug if the drug's caused abnormal liver function tests, because it can then get worse. So on a monthly basis, we check them up. So initially, the FDA approved the use of Tolvaptan for people who had rapidly progressive decline in kidney function, and we'll go into that. And so if somebody is in that stable group that I talked about early on, that 16% where there was no decline, there's probably no benefit in taking Tolvaptan. So what we want to do is give it to people who are likely to benefit from it. But, like with anything, any drug has got side effects and benefits, so we need to weigh up the risk-benefit profile. So this is something that I think is quite useful for people to think about. So if we look at this is just extrapolation of data. Obviously, we don't have data going out 25 years in using these drugs. But if we look at the rate of decline of kidney function with tempo, it was 3.7 mils per minute per year. So nearly 4% decline per year in the placebo treated, and 2.7 per year in the Tolvaptan treated. So if you started at 90% of kidney function, and you could have 90% in the tempo 3/4, it was above 60, then you would gain about 7.3 years off dialysis or off end-stage kidney disease. If you started a bit lower, you tended to get 4 to 5 years off dialysis, and there were very few numbers down here because you weren't supposed to be in the study if your GFR was less than 60, but a few people snuck in. But if we look at the Reprise, where the data is a bit better, even if you start with a GFR of 30, you still get a couple of years off dialysis compared to if you're on placebo. If you start with a GFR of 60, you still get 7 years longer off dialysis than what you would do if you were treated with placebo. Now, this is all extrapolated data, but there's nothing that would make me think there's anything that the data would be inconsistent with. So after the Americans introduced Tolvaptan, then the Europeans, this is the European Renal Association and the European Dialysis Transplant Association, they then developed this algorithm, which is a bit complex, but basically it also says that if you are a rapid progressor, then you have an indication for treatment. So the rapid progression is defined as a confirmed decrease in your GFR of more than 5 mils per minute per year, or on average in the last 5 years, have you declined more than 2.5 mils per minute per year over that 5-year period. So that means that 12.5 mils per minute on average over the 5 years previously. There's also a requirement or a potential to be on Tolvaptan if your kidney has increased in growth, or if you have a propensity score for worsening of polycystic kidney disease. We don't tend to do this in Australia. We don't tend to do a lot of genetic testing, and the PRO-PKD score it requires genetic testing to be done to develop it. Also, there's this issue that people who have ADPKD tend to have the same pattern that runs in families. So if your mum ended up on dialysis at the age of 65, you're probably going to end up on dialysis around that age. So if people have a family history where kidney failure was reached at an age that was relatively young, then you tend to be more likely to be treated with Tolvaptan. So these things change. Basically, what Australia have mainly used is this eGFR decline of more than 5 mils per minute in a year, or an eGFR of more than 2.5 per year over 5 years. So that might mean for some of you that you would have only been seeing your doctor every couple of years. And now you might see that we're saying, why don't we see you in a year, so that if you do qualify, you may well be started on Tolvaptan a little bit earlier, or your GP needs to know about these. But as it stands, GPs can't prescribe Tolvaptan, so you may necessarily want to either be hooked in to see a nephrologist on a regular basis, or at least get the nephrologist to see your blood test results so they can be in contact with you if you qualify for treatment. Because as everyone knows, you feel fine with kidney disease until your kidneys don't work any longer. So this is the criteria whereby most people in Australia So I won't go through this, but this is this PRO-PKD score, but it looks at the mutation and also, hypertension, etc. We don't tend to use it because most people we don't do genetic analysis on. So in Australia, the treatment criteria are that the patient must be treated by a nephrologist, and you have to have an eGFR between 30 at initiation, and you also have to have rapidly progressing disease, as evidenced by that 5% reduction or 2.5% per year on average. So there is no upper age limit. It just needs to fulfill this. There is a lower age group of 18. So there are a couple of contraindications. So people need to be non-pregnant and not breastfeeding, and to be using appropriate contraception. Liver disease we exclude because the drug can cause liver abnormalities. Some people have polycystic liver disease in association with their kidney disease, and their liver abnormalities tending to be very stable, so that doesn't exclude them. If your level of sodium in the blood is high, then that reflects the fact that you need to drink more, or you're not sensing appropriately that you need to drink more. So you can be at risk of dehydration if you take Tolvaptan under those circumstances. And again, if you're dehydrated, so if you have vomiting, diarrhea, we tell people just suspend the Tolvaptan whilst you're unwell. And certainly, if you end up in hospital with a stroke, or you're under anaesthetic and you can't respond to thirst, absolutely don't take the Tolvaptan on that occasion. No urine output, that's acute renal failure. Obviously, we don't want to give you something that's designed to increase urine output if you don't have any. And obstruction to urine flow is a precaution, but not an absolute contraindication. So some people with prostate problems can find that their prostate is more irritating, and it may cause an issue that might mean that you need to get your prostate issues addressed or take other medications for prostate, to improve your urine flow. And obviously, if you've got an allergy to a medication, you don't take it. So liver toxicity, we worry about it, but it's, really infinitesimally small, but it's required that we look at your blood test results It used to be a requirement that we would, report back to the department that we'd seen them, we'd seen your blood test results, and now I think the Department of Health unusually trust doctors that we will appropriately look at the test results. It is a bit of a hassle, the month goes very quickly when you've got to have a blood test every month. So I think it's just how it is for the first 18 months. But as I say, it's been, a very unusual situation, but obviously, we want to avoid it. There are with Tolvaptan, so you do need to be aware of these, and your doctor needs to be aware of them. So there are some drugs that come in contact with. They're drugs that are used for fungal infections, like systemic fungal infections, not just for thrush or something like that, but for major blood infections, and some HIV-related treatments. Also some relatively common drugs that are used for blood pressure treatment, like diltiazem or verapamil. So that's cardizem and amiodarone that slows your heart rate down. So that's cortisone. Erythromycin, which is an antibiotic, fluconazole. People will take 1 dose of fluconazole for thrush. That's not a problem. It's only if you take it recurrently. And grapefruit juice. So that changes the absorption. So if you're on Tolvaptan, don't have grapefruit juice, like a bottle. You can have half a grapefruit every so often. Who has, 10 grapefruits a week. Diuretics we tend to avoid because part of their mechanism of action is that you lose fluid here. So we don't, we tend to stop diuretics. And then probably more commonly statins, which are cholesterol-lowering drugs, particularly rosuvastatin, and Lasix, and methotrexate, which is a drug that people use for arthritis mostly. The Tolvaptan can increase levels of these drugs, more significantly a problem with methotrexate, but occasionally if you've got kidney impairment with statins. So just be a bit aware of that, and just ask your doctor to just check whether or not there's any drug interactions. So just a case study. So this is somebody who was a 48-year-old teacher. The creatinine 3 years ago was 52, and now it's 38. And so clearly qualifies for rapid progression because there's been a decline of more than 2.5 mils per minute per year on average over the last 3 years, not even 5 years. So what needs to be done is we need to explain the risks and benefits to a patient. So you will get a patient leaflet that will say, these are the risks, this is how you mitigate any problems. You do need to agree that you will have blood tests monthly for 18 months and thereafter every 3 months. Mostly people with significant kidney problems will have a blood test 3 to 6 monthly anyway. I don't think that's a big deal. But the monthly issue is something that it can be a little bit of a hassle, so you need to get that into the routine. What we need to do as doctors is we need to ask you to sign a consent form, and then we ring up the Department of Health and we get approval. And then there's a possibility that you can join a program that Otsuka have set up that mean that you get reminders to do blood tests, and also there's support materials. And then basically the scripts after we've checked your blood tests, and that will happen on a regular basis early on because the dose changes, the dose increases until you get to the maximum dose, and then we give you a 6 monthly script. So I think that's about all. And then I think that there was going to be an opportunity for some questions and answers. So we've got a a couple of questions here, and then I've got some questions from that were sent in previously. So maybe I'll just address some of these. That somebody's young son has been recently diagnosed with polycystic kidney disease, and no one has mentioned the relevance of the size of the kidneys. So I think ask about the size of the kidneys. It is relevant. For a young person, and this person does seem to be under the age of 18, the kidneys will continue to grow. It would be very unusual for somebody under the age of 18 to have, quite large polycystic kidney disease, and there to be a decline in kidney function. So if there was a decline in kidney function, that would be a sort of an alert to get some genetic testing done, because most people, wouldn't end up with problems with their kidneys, until middle age. So if there is, any suggestion that there's impaired kidney function at 15, that would be referral to a geneticist. But I think, following the size of the kidneys, not too frequently, but if, say, he was 15, I would probably do it in 5 years and see whether or not there'd been a significant decline. Then I've been asked about whether or not I've been chosen to present about Tolvaptan because the results are promising for this treatment. I think that the issue is there's no other treatment that's been approved for ADPKD. So I think, up until about 2000, there was no drugs that were beneficial for kidney disease at all. So in 2000, there was benefit shown for diabetic kidney disease with blockade of the renin-angiotensin system. So those drugs that I mentioned that were used in the HALT study, they demonstrated a slowing of about 16% in the development of end-stage kidney disease. From then up until last year, there were 0 drugs that were beneficial for people with kidney disease. And then in 2019, a group of drugs were shown to be beneficial in people with chronic, with diabetic kidney disease, nothing with PKD. I think I'm talking about this because this seems to be beneficial. I think if I had PKD and declining kidney function, I would, I would be taking it. Somebody thanked me, thank you. 2 questions after the first tablet of the day, you're not supposed to eat for 30 minutes. Does coffee or tea count? Second tablet, take 8 hours after the first. Whether any evidence, whether it's better to take 8 hours or later in the evening. So I think the issue about not eating is you don't want to interfere with the absorption of the drug. So you can have coffee and tea, you can drink, but it's just some foods will bind drugs. So just be careful of that. And the second tablet in the day, take 8 hours after the first. I think it's better to take as close to 8 hours as possible. So take the first tablet as early as possible, the second tablet 8 hours later. If you take it too late, you might find that you get up at night to pass urine, and that can be more irritating. People with kidney disease will get up at night anyway. And if you're on a drug that makes you pass more urine, that interrupts your sleep even more. So male individuals over 60, stage 3B, so that means a percentage kidney function of between 30 and 45%. Recent rapid growth in kidney size, but gently decline in kidney function. Would Tolvaptan help? Yes, look, I think it would. What you don't want to do is get to 80 and then somebody tell you that you need to be on dialysis, because when you're 65, if you're on dialysis, then, transplant, and there's other options. But when if it goes on a bit, I think it's, you sort of almost put your head in the sand and hope it won't happen. But having a conversation about what sort of dialysis do you want when there's no option for transplantation when you're an older person, I think it's tricky. So if there's been a rapid growth in kidney size, portends a subsequent decline in GFR. So I would be thinking, I'd certainly take it, or I'd recommend that you think about it. Side effects when people take Tolvaptan. The main side effect is the polyuria, as in you pass too much urine. So people that have Tolvaptan, the mechanism is it stops you from reabsorbing fluid, and because of that, you pass more urine. Beyond that, there's the liver function abnormalities, there's the dehydration that you don't need to, you need to make sure you keep drinking. And then there's the issue with the drug interactions that I spoke about. I don't think that there's too many problems beyond that. Most people complain about the polyuria, and there's little you can do about that. You just have to sort of manage it. Most people seem to be able to manage it. I know some people who are, for instance, truck drivers or people that can't get to a bathroom easily. That can be a problem. So I think you have to preempt where you're going to find a bathroom, but there's nothing you can do to manage that. Does it help polycystic liver disease? No, it doesn't. That's sort of a different mechanism and usually a different mutation. Why don't we remove polycystic kidneys after transplant in Australia when they do in America? Look, we sometimes do remove polycystic kidneys. It depends on how big they are and whether or not they're sort of causing a problem. So some people had very big polycystic kidney disease before transplant, and they just can't fit in another kidney into their abdomen. So we do have to take out a kidney to be able to fit in the other kidney. There's also the issue of surveillance. So there is a slight increase in risk of cancer in somebody who's got a polycystic kidney, and it's very hard to pick that up on imaging because sometimes, because the kidneys are all distorted, it's hard to pick what looks like a cancer and what just looks like a polycystic cyst. So we will often take out one kidney to put in another kidney, and then we'll have a discussion about removing the other kidney post-transplant. If somebody is having what's called a preemptive transplant, so say they're getting a kidney from a relative, then and they need to have the kidney out, then what we do is we organise a date for the transplant, and if you take that kidney 6 weeks earlier than that, that will mean you need to be on dialysis, because taking out a kidney often will mean that they're just left with not enough kidney function. And so we get the date for the transplant, we take out the kidney 6 weeks beforehand, and we do dialysis through a temporary access, and then do the transplant at the time that we planned it. And then we might consider going down the track and doing the nephrectomy, of kidney removal of the other one. I think it's very dependent. Has somebody had urinary infections? If they had stones in that kidney, is it causing a problem or not? It's not, the same rule for everybody. When should a young adult be tested? Basically, it's a ultrasound that people will normally have in Australia. Mostly I don't do tests on young adults until they're over the age of 18 because we can't really do much about it. I suggest that they have checks on their blood pressure, because if their blood pressure is high, then there's benefit. But I always think it's a problem with adolescents if you tell them that they've got a chronic disease. They don't necessarily make good life decisions, and they might change what they think their opportunities are for the future when they absolutely shouldn't do that. So I don't tend to screen people unless there's a reason to do so, with stones or hemorrhage or something else, until they're 18 as a routine. And then if it's negative, then I tend to do another one, early 20s. And if that's negative, they don't have polycystic kidney disease. I think somebody's saying that they're going to ask their nephrologist about the size of the kidneys and the GFR. Then there's a question, are we just supposed to drink to thirst? Yeah, look, that's a pretty good guide. If you're thirsty, you need to drink. I think some people think if I don't drink, I'm not going to pass as much urine. That won't happen. You need to drink if you're thirsty. In general, if you're dehydrated, your weight tends to drop. But look, most people with polycystic kidney disease, if you're thirsty, drink. There's no set amount. It depends a little bit on what your baseline kidney function's like as to how much urine Tolvaptan will make you pass. But in general, it's about how much urine you're passing plus another cupful or so. But nobody knows how much urine they pass. So just if you're thirsty, and then you're having blood tests every month, somebody will tell you if you're not drinking quite enough. I think there was just a couple of other things. There was somebody under the misapprehension that Tolvaptan wasn't recommended for people over the age of 50. That's not right. I think that might have been the initial sort of approval for the TGA, but now that's not the case. So you can have it if you're an older person. And then there's a concern about whether or not a bladder prolapse could be a consequence of extra fluid in the bladder. And look, if you've got a weak bladder, in inverted commas, and that's often the result of childbirth or other complications. Yes, if you put more pressure in the pelvis by virtue of having a full bladder, then that can exacerbate a prolapse, and it can exacerbate prostatism. So that might be something that is very variable for different people. I think that the issue about the safety and effectiveness of Tolvaptan is much better. People who are under the age of 55, there's no problem with the safety over the age of 55, but probably there haven't been as many people studied, so there's no contraindication for use in older patients. But we do need to have those conversations about things like bladder prolapse and prostate, etc. So somebody asked me about fatigue. Fatigue isn't really, it doesn't get into the blood-brain barrier, so it doesn't get into your brain to cause fatigue. Fatigue I can only see as if you're getting up at night to pass urine, so maybe try and move the Tolvaptan earlier in the day. I don't think, somebody asked about controlling the growth of cysts. Can it reduce the size? It doesn't really reduce the cyst size if they're already enlarged. So what do I expect to happen to my GFR when I take Tolvaptan? As I said, sometimes it can drop and then it will stabilize. Drinks you should avoid, soft drinks and alcohol. Look, to be honest, alcohol doesn't cause that much of a risk with your kidneys. Obviously, I can't condone that anybody drinks too much alcohol, but it can cause liver problems and it can put your blood pressure up. Soft drinks, similarly, sugar, problems with diabetes, and I wouldn't do that. And I think that's probably, I've covered all of the questions. Here we are. I've got another question. It seems only rapid progressors could benefit. Could that criteria be limiting? Look, that's just the criteria that the government have put on it. If people are going to be stable, they'll probably stay stable. And that's why you need to be why it needs to be looked at on a regular basis. And I think the government always have a view as to, cost benefit, and the benefit isn't so much there for people whose decline isn't sort of very obvious. And then somebody's asked, if I stay hydrated and drink a lot without Tolvaptan, can it have the same effect and preserve kidney function? That's something that we sometimes get asked, because if you drink a lot, and there is a trial going on about preserved water drinking, it can reduce the endogenous level of vasopressin. So it doesn't block the receptor, but it just reduces the amount of vasopressin that you have. Now, nobody's ever demonstrated that that's beneficial. There is a theoretical benefit, but I think it's quite hard to keep drinking to the point where you have a sustained block in vasopressin. Theoretically, yes, there is a trial going on, but I can't tell you that that's going to have the same effect. How long can Tolvaptan be used for? For the moment, all we've got is the safety data that's been extrapolated for up to 11 years. And I think the longer it's used for, it doesn't seem that there's any attenuation in the benefit. So I think, once you start it, if you can tolerate it, you keep going. You can't start it if your GFR is below 30, but you can continue it if your GFR is below 30.
Thank you, Carol. You've done a great job at explaining everything to us, and we really appreciate your time and would like to extend our thank you. And thank you everyone for attending. I hope you found it as useful as I have.
No trouble. Okay. Have a good night, everyone.
You.
Bye.
Bye-bye.